Welcome, ladies and gentlemen, to the last section on radiology of the appendicular musculoskeletal system, where we will be looking at the pelvic limb. I am Dr. LaRue, and I'll be giving these lectures. As for any other body part, two orthogonal views are needed to complete the study. These include the ventrodorsal and the lateral view. For pelvic evaluation, it is not necessary to include the stifle joints, but please note the difference for positioning for hip dysplasia certification, which is covered in the next section. On this slide, please hit the pause button and take some time to familiarize yourself with the normal pelvic anatomy. This slide shows the four major components of each hemipelvis, namely the ilium, the pubis, the ischium, and the acetabulum. On this next slide, the bones are divided into their separate components. Again, hit the pause button and take some time to learn these. The acetabulum is made up of a confluence of the three other bones. The first condition we'll be looking at is hip luxation, or coxofemoral luxation. This occurs mostly in a craniodorsal direction due to the pull of the gluteus medius, which inserts on the trochanter major. 80% of these will be seen to be craniodorsally displaced. For example, in this VD radiograph, the femur head is seen to be luxated outside of the acetabulum in a cranial direction, and the lateral view helps determine that it is also in a dorsal direction. Traumatic causes are the most common. In immature animals, femur head physial fractures or Salter-Harris 1 fractures are more likely than luxations because the physis is the relative weak point. On clinical exam, with a patient placed in dorsal recumbency, the affected leg will appear shorter. This is because the femur head is displaced craniodorsally. Here I've just included an interesting example of a skeletally immature patient which has suffered a Salter-Harris type 1 fracture of the femur head as well as a femur head luxation or coxofemoral luxation, which is quite interesting. In these cases, it's important to carefully assess the radiograph for avulsion fractures of the femur head coming from the insertion of the capital femoral ligament or for acetabulum rim fractures. This is because the presence of these will affect the treatment choice. Surgery or open reduction will be required in these cases. In this radiograph, there is a triangular shaped fragment located within the acetabulum with a fracture bed within the femur head, consistent with a femoral head avulsion fracture. Hip luxation may be chronic or acute. In acute cases, like on the left-hand side, there are no secondary bony changes present. In chronic cases, for example, the right-hand side, there might be periosteal reaction on the lateral shaft of the ilium. This is due to the persistent rubbing of the femur head against the ilium, and the acetabulum might start filling with new bone because of the absence of the femur head. Pelvic trauma refers to any fractures, subluxations, or luxations. The diagnosis of sacroiliac subluxation is aided by the symmetrical appearance of the pelvis. So obviously this is only if it is a unilateral occurrence. The easiest way to look for this is to look for step formation at the sacroiliac junction caudally. For example, on the right side of the patient, there's a nice smooth transition from the ilium to the sacrum, versus on the left-hand side, there's step formation between the sacrum and the ilium, consistent with sacroiliac subluxation. The pelvic box or the pelvis can be seen as a symmetrical box shape and can only be disturbed if there are either 3 fractures that are displaced or 2 fractures and a sacroiliac subluxation. For example, in this radiograph, there is a presence of a sacroiliac subluxation as well as 2 fractures of the right hemipelvis at the pubis and at the ischial table. This results in slight cranial displacement of the left hemipelvis and the right pelvic floor. Here's an example for you to take some time to identify the pathology on this VD pelvis. You can hit the pause button and take a few minutes to identify all of them. Oops. So here there's the presence of a right-sided sacroiliac luxation or subluxation. There's step formation between the sacrum and the ilium. There is a right coxofemoral luxation with cranial displacement, and if an orthogonal view is taken, one will probably see that it is dorsal as well. There's a fracture of the right ramus cranialis ossus pubis, and there's bilateral fractures of the ischial plateaus. The next condition we'll be looking at is Legg-Calve-Perthes Disease, or LCP. This is also known as avascular femur head necrosis and occurs in young, small or toy breeds between 4 to 12 months of age. So the signalment in this case is very important. Radiologically, it usually occurs unilaterally, but often bilaterally at a histopathological level. It is associated with a decrease or lack of blood supply to the femoral capital epiphysis. So the pathophysiology is as follows. There's necrosis of the subchondral bone, but the overlying cartilage can continue to grow. As revascularization occurs in an attempt to repair the defect, the removal of necrotic bone causes a decreased opacity of the affected femoral head, seen on radiographs. Incomplete removal of necrotic bone and invasion of granulation tissue interferes with healing. So the end result is a misshapen femoral head of non-uniform opacity. With early LCP, one will visualize a widened joint space. This is because of the thickened cartilage that keeps growing, and there's no endochondral ossification of it that can take place. And this cartilage is also prone to microtrauma. And the result is moth-eaten lysis of the femur head. So in this example, there is a widened joint space. And this femur head or the epiphysis has a mottled radiolucent moth-eaten appearance with some irregularity. Here's another example of an early case. What's nice here, because it's unilateral, is that one can compare it to the normal side. So the left side is normal, and the right side is slightly irregular with a widened joint space visible, as well as a mottled radiolucent appearance to the femur head. And here is a image of a surgically resected femur head that was affected by LCP, and one can see the collapse and the cartilage fissuring present. With late LCP, one can see collapse of the subchondral bone with flattening of the femur head. There may be widening of the femoral necks due to osteophyte formation, which is an indication that there is arthrosis present. And then coxa vara is also present. This is the decrease in the angle of inclination between the neck and the femur shaft. So on a well-positioned VD, there should be approximately 130 degrees between the neck of the femur, and the femur shaft. Coxa vara means that this angle becomes closer to 90 degrees. And I'll show this on the next slide. For example, here's another case of late LCP with total collapse of the femur head, which is also widened. On the normal side, even though this is not a perfectly positioned radiograph, the angle between the femur neck and the shaft is about 130 degrees, whereas on the affected side, it becomes closer to 90 degrees. Right, here's another example for you to figure out what the pathology is. Hit pause and then have a look for a few minutes before looking at the answers. Okay, in this case, there's bilateral sacroiliac subluxations. You can see the step formation bilaterally. There's a comminuted fracture of the left caudal ileal body with extension into the left acetabulum with a large fragment in between. You can see there is part of the acetabulum remaining over there. So it's important to try to identify joint involvement. There's also a sagittal fracture through the pelvic symphysis. Here's another condition which we covered a few lectures ago, and see if you can identify the pathology and make a diagnosis. The signalment in this case is that it is a young, large breed dog. In this case, the diagnosis was septic arthritis, which is quite uncommon. If you look carefully, that there is subchondral lysis of the femur head, as well as some reactive new bone along the lateral ileal shaft. Here's another example to see if you can make a diagnosis. In this case, there is a right coxofemoral luxation with a Salter-Harris type 1 fracture of the distal femur. Lastly, another condition which we mentioned a few lectures ago is bursitis calcarea. This is just the term referring specifically to calcifying tendinopathy of the insertion of the gluteus medius on the trochanter major. So bilaterally, there are these mineralized opacities that occur just dorsal to the major trochanters, and it is incidental. So this is the end of the lecture on the introduction to the pelvic limb. The next lecture we'll be looking at hip dysplasia specifically.